Sir, I'll start, sir.
Ward rounds are good evening, everybody. Welcome to today's ward rounds. Ward rounds are designed to test the candidate's knowledge of pre-operative assessment and bedside, knowledge, and also post-operative management of patients. So this will not be too much of theory. It's just practical questions about how you manage a certain situation. So Ainas, you can start presenting.
Yes, sir. So the first case, a 21-year-old male came with complaints of pain in the abdomen, vomiting, loose stools and fever with chills
Einass,
since
1
3
second.
days.
Sir, Rajesh
Yes,
Ballal
ma'am.
sir has joined.
Good evening, sir.
Good
I'm
evening.
enjoying myself. Good evening, sir.
Thank you for your wise
Yes.
counsel.
Yes, sir.
Thank you. Start.
Yes, sir. A 21-year-old male came with complaints of pain in abdomen, vomiting, loose stools, and fever with chills since 3 days. Pain in abdomen was more over the right side, intermittent in nature, and partially relieving on medications. He had complaints of multiple episodes of vomiting, non-projectile in nature, and low-grade fever, intermittent in nature, associated with chills. 4 to 5 episodes of loose stools, non-blood tinged, and had no significant medical or surgical history.
Yeah.
On
Stop.
Yes, sir.
Okay. You present the findings. Yeah.
Okay. The examination findings, he had a temperature of 101.7 degree Fahrenheit. Otherwise, the other vital parameters were stable. The per abdo examination showed the abdomen was soft, tenderness was present over the right hypochondrium, lumbar, and the iliac region, and there was no guarding rigidity, and the bowel sounds were present.
Okay. Vinod,
Yes, sir.
with this history and examination findings, what are your thoughts? 21-year-old with vomiting, diarrhea, fever, chills, abdominal pain.
Yes, sir. Sir, fever with chills, mostly some collection, I feel some inflammatory pathology is happening in the abdomen. So probably in the right hypochondrium and the right iliac region, maybe like cholecystitis with empyema or appendicitis with abscess collection, sir.
See, you have to think about common things first. Somebody has 21-year-old, no
Yes, sir.
previous history of any problems, comes with abdominal pain, vomiting and diarrhea, fever. What do you think of first? You are going
Obstruction.
not about why should you have diarrhea with obstruction?
Partial obstruction, sir.
So you have no other thoughts. Let us now ask others. Let's start
Acute
with
G.
G.
yeah,
G.
acute. Why can't you think of gastroenteritis? No,
But sir, fever with chills and rigor in G.
see this one, the chills may be something that I don't know whether he has had rigors, but chills may be something it is an individual perception. Though I would agree that chills and rigors is usually with malaria, urinary tract infection, and cholangitis. But still, disregarding that, all other symptoms, young fellow, sudden onset, abdominal pain, nausea, vomiting, diarrhea, I think you should think of gastroenteritis first.
Okay, sir.
No doubt about that. And then, second thing, as you said, because it's a very short-lived history of
Yes,
3 days, it's a bit far-fetched to think that it is already perforated with abscess and then causing diarrhea.
okay.
Okay, on clinical examination, if so, that it is likely that you are thinking of this it is being appendicitis with perforation. How would you potentially confirm that? Forget investigations clinically.
Sir, if it is right iliac fossa, tenderness in the local guarding.
Tenderness guarding and possibly
Rebound tenderness.
no, rebound tenderness guarding, all that is about the same thing. It indicates
Yes, sir.
peritonitis.
Yes, sir.
What else potentially makes you think, oh, maybe it is that? And another examination I would like you to do before you commit whether clinically you can make that out or not. Anybody else?
So bowel sound, sir, would it make a difference?
Bowel sounds are
Silent.
very, huh?
Migrating pain.
No, I'm talking
No
about sign.
tachycardia.
Talking about sign. Abdominal sign. And another examination you are permitted to do. See, if for example there is a mass in the right iliac fossa, that strengthens your thought process that it may be possibly an abscess. And then you do a rectal examination, and in rectal examination, potentially on the right side, you may feel a bogginess or tenderness over that side. And if it has already formed an abscess there, and that would potentially be causing what is called a spurious diarrhea.
Oh, yes, sir.
So that is, to try and fit all your symptoms and signs into one diagnosis. If you want to, it's not always necessary to do that, but if you want to explain all the symptoms the patient has, you have to think about it being an appendicular perforation with an abscess, and that abscess causing spurious diarrhea. So that will explain vomiting, abdominal pain, diarrhea, fever, everything. Rajesh sir, any more additions? Rajesh sir, are you there? Hello?
There is
Okay.
there, sir, but
Sanya, any other possible diagnosis? Nitya, Sanya, Nikita, Praveen?
Yeah, I have one question. Why is your considered only 68 when the man has fever? 21-year-old boy. Is it?
Are you hearing Dr. Rajesh?
no, sir.
Professor Ballard?
Some voice breaking, sir.
No,
Can
sir.
you hear me?
Lot of disturbance, sir.
So I thought it was my connection being a bit loose or something.
Can you hear me, sir?
Ajay, what do you think? Young patient with abdominal pain, vomiting, diarrhea, fever. What are the likely diagnosis?
Uh,
Ajay?
Sir, I can hear you, sir.
Yeah. What are your likely diagnosis? What are you thinking?
Sir, pelvic appendix, where the appendix is irritating the rectum, and appendicitis.
Appendicitis or even in perforation with abscess.
Yes, sir.
Perforation with abscess.
Yes, sir. Yes, sir.
Because temperature is 101.7. Usually with appendicitis alone, you may not have such high temperature. So
Sir.
you will have to think of one of the complications of appendicitis, which is a perforation and abscess formation.
Sir.
Nitya, Nikita, any other diagnosis with this patient?
No, so this would be our provisional diagnosis, sir.
Okay.
Typhoid could be thought about, sir.
Why vomiting in typhoid? Can you have vomiting in typhoid?
We
can have no, sir.
But typhoid, usually the fever is be much higher. He's complaining when you recorded it may be 101, but he complained of low grade fever, right? So typhoid usually will have starts off with a fever which is quite high, and it usually follows a pattern. Of course, you can think of typhoid, but I think more gastroenteritis like picture.
Okay, sir.
Okay, carry on. Hello, Einass.
Yes, sir. 1 minute. Yes, sir.
Carry on.
1 minute. Yes, sir. The investigations, the hemoglobin was 14.1. Then all the investigations were within normal limits. And this was the ultrasound image which was shown, wherein they said that there is a small bowel in the right hypochondrium, which is it is showing like an inflamed bowel with hyperechoic content within it, and for a length of around 7 to 8 centimeter, and it showed a target appearance on ultrasound. It can be
Indicating
seen.
what?
Target sign is classical of intussusception, sir.
Yeah.
Yes.
So,
Yes, sir.
Vinod, is ultrasound sufficient for you to make the diagnosis of intussusception?
Yes, sir. This is more, they are highly saying that is intussusception.
Yeah, if they can commit that it is intussusception, it is sufficient, because
Yes.
many especially in younger children where intussusception is much more common, the diagnosis is made by ultrasound in majority of them. So ultrasound is a good, if they cannot tell, if they cannot see the target sign because abdomen is distended or whatever, then it is different. Otherwise, if they can comment on the target sign and possibility of a bowel within the bowel, then you should accept that is sufficient in terms of diagnosis. Okay, carry on.
Yes. Then further, the CT findings again.
Why did you do a CT? Vinod, why did they do a CT? Was it necessary?
No, sir, not required.
But why did they potentially do it? What prompted them to do a CT? Who was on call when the patient got admitted?
Me only, sir.
Just a minute.
They were evaluating for.
Let Vinod answer. Vinod, any reasons why they got CT done?
Probably confirmatory, and one thing is diarrhea, sir. One is generally it should be if it is they say it bled with stool, sir.
No, it's not always necessary. It can,
Yes.
in later in the course. In the sense, I'm not saying you wait till very late, but it's slightly later in the course of the illness is the red currant jelly. That
Yes,
is
sir.
because of the congestion and the mucus being
Necrosis.
blood stained. Yeah,
Yes.
the mucus being blood stained, and that may happen quite a bit later. But why do you think they requested CT? Think.
To know the cause for intussusception, sir, submucosal lipoma, something like that.
Correct. I think if you can get more information about the
Region
apex
of
or the
intussusception.
Location.
the apex
Location
or
where
where exactly is the thing, and is it complicated or is it simple intussusception? Is there already perforation? Is there collection? Is there free fluid in the abdomen? And all these information can be. And other thing is a young guy, so potentially any other congenital malformation and things may be picked up on CT scan. So which is why CT scan was requested. Is Rajesh Bilal said that there?
Yes, sir. Can you hear me now?
Yeah, very
Yes, sir.
well.
Yeah. Okay, sir. Some
So-
problem with this one. So I changed my
Yeah.
device. That's all, sir.
So far, anything to add, sir?
No, that time I only had one question. Why did the patient have relative bradycardia? Because his
Correct.
pulse rate was only 68 and he has a
Correct.
fever of 101.
Yeah, correct.
And
What is the likely
I'll explain,
reason
sir.
for bradycardia? I wanted to ask that question. Good that you
Yes.
asked it. Vinod? Anybody else?
no, sir.
Any fever you can think with bradycardia?
Sir, I don't think anybody is answering. So
Yeah.
you can
If
kindly.
at all, I mean, somewhere in the back of the mind, you must think of typhoid. sir, because with this CT shows the intussusception.
In the back, we didn't get the thing, sir.
Yeah, in the back of the mind, I think somewhere you must think of typhoid, sir.
Typhoid, yeah.
Yes, sir. Relative bradycardia,
Ah,
which can also explain the absence of physical findings in the abdomen, sir.
yeah,
If at all, sir. Yeah, but that is ruled out with
Okay.
the CT now, sir.
yeah.
Yes, sir.
So, yeah, so carry on, Einass.
Yes, sir. So the CT findings, they said that there was a short segment telescoping of proximal ileal loops, and along with mesenteric fat noted for a length of around 6.5 centimeter, which suggested ilio-ileal intussusception, as this was seen in the right hypochondrium region. Mild edema of the bowel was noted, but uniform contrast enhancement, and the tip of the intussusceptum was showing a oval soft tissue density, which was probably an enlarged mesenteric lymph node, and minimal interbowel fluid was noted. This is the point. Again, the same target sign was seen here. And in the next image, it can show like the intussusception going into the other intussusceptions loops.
Yeah.
Yes.
Okay. So, so what are the other things we know you are likely to expect in this situation? When there is intussusception, it has been going on for how long has been the symptoms, Einass?
3 days, sir.
Ah. So, what else would you expect, Vinod, with patient with tenderness and tachycardia, not tachycardia, but fever?
Collection, sir.
Huh?
Collection.
Perforation. You should
Yes,
look
sir.
for any gas in the wall, bowel wall, indicating that the bowel is gangrenous.
Gangrenous, yes.
And then any free gas around the intussuscepting area, indicating perforation, and then fluid collection, indicating abscess, as you said, or peritonitis, signs of peritonitis, mesenteric thickening, and free fluid in the abdomen. So all of these indicate that there might have been gangrenous of the intussuscepting segment with the perforation. So it's not, when you get the CT done, you should look for all of these things. In addition, the diagnosis is staring at you. Ultrasound made the diagnosis. When you get a CT done, you have to look for other features which will help you manage the patient better. Every investigation that you request has to give you some information towards optimal management of the patient. Okay.
Yes.
Right.
On a CT, is it possible to suspect ischemia for the students?
Students.
Yes,
Isch-
sir. If we do a CECT, then we can comment on the vascularity, sir.
What will you see?
So vascularity of the
Non-enhancement of the bowel loops, sir. Like
yes.
And
Uh, If you give
the
us
air within the wall.
air within the wall, probably, yes. Any idea what it's called? There's a
Pneumatosis intestine.
fair enough, fair. Some examiners want this one called thumb printing.
Yeah, correct. Thumb printing.
Yes, some queer examiners we have, no, sir, who want specific words.
Words, yeah.
Yes, sir.
Correct. Thumbprint, yes, exactly. Right. Carry on. Einass.
Yes, sir. So the patient was planned for diagnostic laparoscopy and proceed. The diagnostic laparoscopy showed intussusception at the mid-ileum, the ilio-ileal intussusception. Laparoscopic release of the intussuscepted bowel was tried, but could not release it. So laparoscopy was converted to laparotomy, and the intussuscepted bowel was isolated and tried to release it, but this failed due to dense adhesions of bowel into it. So the resection of the intussuscepted bowel was done, followed by ilio-ileal anastomosis.
Okay.
Yes, sir.
Just a minute. See, Vinod, if you are handling the intussusception, okay, when you are the surgeon, describe to me how you would do it. How would you try to reduce the intussusception?
Sir, milking, sir.
Huh?
Milking.
Will you push or pull?
Good.
I'll push it, sir, not pulling.
So where will you push it?
From the intussusception side, distal end.
No, yeah, but where exactly? Why will you not? Why will you not
Why
pull?
not pull?
Because the area will be so fragile, there is a chance of tear and perforation.
Okay. So where will you push?
From the distal,
Anybody else? Where will you push?
From the lead point, we have to try pushing.
At the apex or wherever the lead point is, where you feel that the intussusception is starting. So from there, gently push it, and slowly keep, as you said, milking. So keep moving forward till the intussusception is fully reduced. And usually, what else will you do after you have actually reduced the intussusception? Vinod, let us say you have managed to reduce the intussusception. What will you do next?
I'll find out the what is the lead point, sir.
Okay, so you will try to identify the pathology acting as the lead point for the. What are the common pathological causes for intussusception?
Generally, at this patient, at this age, maybe probably Meckel's diverticulum or lipoma.
Meckel's diverticulum is very rare. So don't quote that just because you found that in this patient. Don't quote that as number one.
Okay. Lipoma, sir.
Why lipoma? Anybody else?
Peyer's patches,
Lymphoid
hypertrophic.
Hypertrophic Peyer's patch, correct? Then?
Sir, in this patient, Peyer's patches is possible, sir.
Possible, yeah.
In adults, yes, sir.
Yeah, it is possible. He's 21.
A
Yes,
polyp
what
or
else?
polyps, sir.
Polyps, good. Polyps. Talk about common
Lymphomas.
conditions.
Lymphoma can also, like, can that cause, sir?
Lymphoma, when it is there, but again, it is a rare cause for intussusception. But yes, but think of common conditions first. Anybody else?
Any ingrowing tumor, sir? Ingrowing tumor, sir, towards the lumen.
Yeah, that is a rarer response. But tumors, but in this guy is 21, so unlikely, but it could be. Yeah, polyps, tumors, and then hypertrophic Peyer's patch due to inflammation or infection, and I think mesenteric node, as they had predicted. I don't know, mesenteric nodes can act as the apex of intussusception. Ballal sir, have you seen anything like that?
Don't know. No, sir. I don't think so, sir. Don't think so.
Because they had reported it as the lymph node.
I know. I saw that. Yes, sir.
Yeah.
But I am not.
Unlikely.
No,
I have not seen it.
Yes.
Unlikely. So,
Sir, it is also reported like iatrogenic, sir, like post-operative or any tubes, jejunostomy tubes. How is that like possible, sir? Like in the literature, it suggests, sir.
What?
Jejunostomy tube can result in intussusception.
So there is a fixed point. Because the tube is fixed at one point.
So it could potentially draw the ileum, as it because there is peristalsis. It may potentially, if it is loosely fixed, I suppose, but I don't know. I have not seen it, but it can potentially happen. Meckel's diverticulum itself is a very rare condition. Meckel's diverticulum presenting as a focus of intussusception is even more rare.
Yes.
Just because you've had it here, you can't quote that as number one. Vinod, did you understand?
Yes, sir. Yes.
Okay. So, always examiners will, if you quote the rare condition first, they will somehow get irritated. So, your job is to not irritate the examiner. Keep him pleasant, quiet, then you have better chance of passing.
Yes, sir.
Him or her, rather. Okay. So, Vinod, describe the operating the pictures that you are seeing? Describe.
The first image is the smooth apex area is I feel apex, that is a apex part, sir, and that is a upper one is the proximal segment and the lower one is the distal segment of small bowels.
Okay.
And
Second picture.
here they are trying to milk it, sir.
The reduction. It's not, don't call milking.
Yes,
The
sir.
process is
Reduction.
called reduction.
Yes, sir.
Let us say you have a child with intussusception. Would you operate on the child?
No, sir.
What would you do?
Air inflation is the one technique, sir, and ultrasound guided saline injection is also.
Correct. So, what is that called? Anybody?
Hydrostatic reduction.
Hydrostatic
Hydrostatic reduction of
reduction.
intussusception. So, where will you consider a laparotomy or a laparoscopy? Patient has come to you with intussusception, child has come to you with intussusception. When would you consider surgery straight away?
Or the reverse way of asking is, when would you not consider hydrostatic reduction?
Correct.
Isn't it, sir?
Yes, sir. Yes, sir.
So when we suspect that it's already strangulated or perforated.
Gangrenous.
Yeah, when the child is sick,
Toxic
looking
and
unstable
tachycardic,
patient.
patient, and the abdomen is tender, guarding, and the child is incessantly crying, and the duration of symptoms have been the delay in seeking medical attention. So, and there is frank blood or altered blood in the stools, and in the end when the patient is ill, and then you don't consider doing hydrostatic reduction or ultrasound guided reduction because of the possibility of the bowel already having undergone gangrenous change. So then you would consider surgery straight away. So the final operating specimen, Vinod, what do you think it is? Hello?
Hello, sir.
What is describe the final specimen, the third, the below one.
The lower end is the dissected ileum, sir, and
no lower end, man. It is just the intussuscepted segment which is ischemic and could not be salvaged and hence has been resected.
Yes, sir.
That's all.
Okay.
Okay. Now, after having resected, describe to me what will you do next. Vinod, quickly,
Hello,
man.
sir, because it's small bowel end-to-end anastomosis, sir.
How would you do an end-to-end? Describe how will you do an end-to-end anastomosis?
Intermittent seromuscular. Intermittent.
It's not called intermittent, man. Would you do a single layer, double layer?
Single layers.
So single layer, what is that called? Interrupted subseromuscular.
Yes, sir.
So seromuscular layer is the strongest of the layer of the bowel wall. So
yes,
you have to say interrupted subseromuscular.
Yes, sir.
Okay. So what you have to do is to assess if the two ends are equal in terms of their diameter.
Yes.
Sometimes if there is significant obstruction proximally and the distal loop is collapsed, what would you do? What are the options?
Sorry, sir. Hello.
We are waiting.
Sir, we can do end-to-side on anastomosis or otherwise Cheadle's. We can.
Cheadle maneuver if the incongruity is minimal then you can do a cheatal maneuver and then try to do an end-to-end anastomosis. If there is significant discrepancy between the proximal and the distal ends, then you do an end-to-side anastomosis. Agree.
If you do a
So,
sheetle, you want to cut on the mesenteric or the anti-mesenteric border? Basic question.
Anti-mesenteric.
Anti-mesenteric. Please don't say mesenteric border.
Yes.
What will happen if you cut on the mesenteric border, man?
Vasculature compromise.
The patient, first of all, it start bleeding.
Yes.
Yes. And then you'll have compromise later. Okay. Okay. When will you consider, Vinod, when will you consider not anastomosing? Let us say that this patient is a young patient, but when will you consider not anastomosing? Very simple, man.
Yeah.
Nikita.
So peritonitis and abdomen is very contaminated.
Yeah, fecal peritonitis with perforation. Patient is very sick on inotropic support, and potentially, we wouldn't have done their albumin if we have done their albumin if the albumin is very low.
Low.
And the patient, appears all the conditions that we just described. The patient is in shock or patient is in severe sepsis, peritonitis, fecal contamination, and things like that. Then you would potentially not consider doing an anastomosis. You would bring it out as an ileostomy, and you can do a double barrel also. You can bring it out, bring both the loops out, and then once the patient gets better, you don't have to do a formal laparotomy. You can just peristomal incision and then dissect it into the peritoneal cavity and then do an anastomosis and put it back. So you have to be ready to not do an anastomosis in certain circumstances. So you should know what they are. Okay, Vinod, now you have done the anastomosis, and then you have washed out the peritoneal cavity thoroughly. Would you place a drain or not in this patient?
In this patient, as the patient is acutely came, there is no proximal dilatation, and it is a small bowel anastomosis. We cannot avoid drain, sir. We cannot.
No. See, I always tell you guys, when you are asked a question, would you place a drain? You just answer simple yes or no.
Yes or no.
Let the examiner ask you the question. If he thinks that your answer is not correct, he will ask you for reasons.
Yes,
if he agrees with you, he will not ask for reasons, because it's very simple. Don't invite all this, explanations.
Yes.
Unnecessarily don't, invite questions and irritate the examiner. Okay, so when understand the question, I asked you, would you place a drain? You said no. That's fine. I can ask you, why don't you want to place a drain? If I don't ask you, then you have saved yourself a question, right? So don't unnecessarily invite, trouble. So you have done the anastomosis, you have closed the abdomen. Now, how would you take this patient forward? Describe to me the post-operative, care of this patient.
Sir, I'll keep the patient on Riles tube as because it is a small bowel anastomosis, and from day one I'll start clear liquid.
Riles tube? What will Riles tube do? Is the bowel, see, the thing is, you have to understand, is the bowel dilated, very dilated, and is it atonic?
No, sir, but chance of paralytic ileus.
Chance of what?
Paralytic ileus.
Why would you expect paralytic ileus if it is, you yourself said it's an acute situation? Why would you expect paralytic ileus?
Because resection.
No, if you resect the bowel, it doesn't need to particularly go into paralytic ileus.
Okay.
So, would you adapt the enhanced recovery program in this patient? Is
yes,
my
sir.
question.
Yes, sir.
Why, if you are going to adapt, why are you going to adapt?
As it is a small bowel, it takes very well. and he's an young patient, nutritionally good.
So it's a short history, acute condition. Patient is generally was fit and well before this, and there was not much of contamination. There was no evidence of peritonitis and small bowel anastomosis. Small bowel doesn't usually, the ileus is not so common, and unless there is reason for ileus, so you would, you don't need dried stew. And he's a young patient, you don't need to catheterize him. You give him IV fluids because he's had a lot of vomiting. So just check his electrolytes and make sure that you supplement potassium and sodium. Allow him orally, and then depending on his progress, you can gradually increase his oral intake. And because the and monitor is, of course, you have to monitor his urine output and everything, but you don't need to catheterize him, and mobilize the patient, and chest physiotherapy, all these things. And depending on the progress of the patient, you can gradually taper the intravenous fluids and increase the oral intake, and monitor the time to passing of flatus and stools, and then discharge the patient as and when you feel the patient is better. So this is how you have to describe the post-operative care of the patient. Ballal sir, anything to add?
Yeah, I have one basic question. I want to give the patient 100 ml of IV fluid per hour, and I don't have a dosimeter. How do I calculate the drip rate?
Anybody can
Anybody?
answer that.
I don't know names. I'm sorry.
Yeah, that's fine, sir.
Sir, actually, by number of drops per minute or number of drops per few seconds we can calculate.
Give me a number. Maths is fairly poor. Otherwise, you tell the sisters give so much, and the sisters will say 5 hours. But that's not scientific.
Anybody?
The lady was saying something. I don't know who, but she was saying something.
Nikita.
Sir, yes, sir. Sir, around like 15 to 20 drops per minute, sir.
What is the calculation?
Sir,
how did you get this answer?
Each ml will actually break it down to 50 drops, sir.
50.
No, I don't remember, sir, exactly. It was a calculation.
They're very
18,
specific.
18 drops, sir.
Most of us 16 drops make 1 ml.
1 ml, yes.
So if you give 16 drops per minute, you get 1 ml per minute. That is 60 ml per hour.
Yes, sir.
Per hour. You give 30
So if
drops,
you want to give 100 ml,
give 30 drops.
Around
30 or 32
25
drops.
to 28,
Yes,
sir. Yes.
Yeah.
Around that, sir. And you need to know this because not all of us will practice in corporate hospitals, isn't it, sir?
Yes.
Yeah, correct.
Isn't it, sir?
So here the situation is that though this is a post-operative situation, and the general rule now is of obligatory underhydration.
Underhydration.
Because the patient has had significant episodes of vomiting, you have to ensure that patient is hydrated properly, unless you have done it preoperatively. So you will have to aim for an urine output in the region of 30 to 60 ml per hour, and then obviously maintain his vitals. So initially give him maybe 100 ml per hour, and then gradually reduce as and when the oral intake increases. If the patient, on the table, if the bowel is very dilated and atonic, you would be justified in passing a nasogastric tube and keeping it till such time that the nasogastric output reduces and the patient starts passing flatus or has a bowel movement and the abdominal distension comes down. So it has to be, don't be dogmatic about anything.
Sure.
It has to be based on the condition of the patient, how fit and young general condition of the patient is, and on the operating table, what was the status of the bowel. If the bowel is very dilated and atonic, I think it will be foolish to start allowing him orally. You can allow him comfort sips, but you should not bank on him taking orally till such time that the bowel recovers from the surgery and from the the insult of the condition. So it will take time. So in that situation, you will have to give him IV fluids and monitor the patient. What are the potential complications, man?
So hemorrhage and hello.
Why hemorrhage?
Maybe reactionary something, loss of some knot.
So you
That's bad.
don't trust the
Yes.
surgeon.
Highly ileal resection, if it bleeds, is bad surgery. No, sir.
Correct. See, I think as students, what I would request you is, especially in emergency situations, when you are operating, at least all the major vessels, suture ligate them, because at least it will ensure that your sutures, because sometimes it's not just your technique, because if there is edema and the sutures will become loose when the edema reduces, and then it may slip out and that may start bleeding. So hence, especially in emergency situations, at least all the major vessels kindly do a suture ligation, because that will be more secure. So hemorrhage, agreed. What else?
Paralytic ileus, sir.
Correct.
We discussed.
Yeah, and very rarely leaks, sir.
Not very rarely, but potentially it can happen. Anastomotic leak.
Infections.
What are the main things that will, what are the reasons for anastomotic leak?
Sir, nutrition, improper technique, and
no, those two are later, man. First thing. Would you leave the segments longer than the mesentery or shorter than the mesentery? Which means you understood the question, no?
No, sir, sorry.
At the edge, is there mesentery or no? That's what sir is asking.
Yeah.
At the edge of the bowel that you cut, should there be mesentery or no?
There should be mesentery, sir.
Correct. So first thing is vascularity. So
Yes,
you
sir.
should have, pink, healthy looking, bleeding, bowel ends, which is pink and well vascularized. So that is the first requisite of a good anastomosis. Second requisite, I told you, no. What is the second one? Three things. Tension. So small bowel, generally that question doesn't arise, but still there should be no tension on your
Tension
anastomosis.
free. Yes.
So it should be tension free. And third thing is, of course, your technique. So technique, always hone your technique properly. Do it the same way every time. It should be metronomic. You should follow the same steps every time. You don't miss out on any step, so that you ensure that you are following a particular technique, with metronomic efficiency. That is the only way to ensure that you do anastomosis properly. Never deviate from that. So that is technique. And then, as we said, fourth later, nutrition, and then other comorbidities, patients who are on steroids and immunosuppressants and renal failure and all these things. So those things come later, but the three most important thing: vascularity, tension, and technique. These three things should always remain constant. So, and then anastomotic leak, collection, and then what is the other complication, major complication, which nobody has mentioned so far? Vinod?
Infections.
Huh?
Infections.
You said infection, collection. You said that already.
Yes, sir.
Nikita? Praveen?
Obstruction can happen, sir.
Very
Again.
good, excellent.
Lumen. Yes.
Post-operative obstruction is a common thing. It can happen on day 1, it can happen on day 5, it can happen on 5 years down the line or 20 years down the line. So obstruction is definitely one of the things. So what are the potential reasons for obstruction?
Bowel edema,
Huh?
sir. Edema of the bowel, sir, during healing
Why
process. Partial.
will edema of the yeah, maybe, but more than that.
Stenosis.
Stenosis
Like
is later, man. So it
So
won't
what I
happen
mean
so
is
early.
short,
lumen,
lumen
lumen
narrowing,
Huh?
narrow lumens.
If your anastomosis is not wide enough, that can because of the edema, it can cause obstruction. If you have not closed the the defect in the mesentery properly, a loop of bowel can get through that,
herniation.
and that can cause obstruction. And then
Adhesion.
adhesive bands can form post-operatively, and that can cause obstruction. So these are the causes. Okay, so intestinal obstruction, potential leak, anastomotic leak, and interloop abscesses, pelvic collection in the abdominal cavity. All of these things are complications. In addition, you can have chest infection, urinary tract infection, especially if you have catheterized the patient. And if the patient is not mobile enough, young patient is unlikely, but EVT, pulmonary thromboembolism. So these are all the complications you should list out whenever you are asked. And then you should know how to. That is why the ward rounds, you do follow the SOAP regime to subjectively assess the patient, objectively assess the patient, and form assessment of the patient. Is the patient status quo, deteriorating, improving? And then you make your plan as to whether you step up the treatment or whether you step up his feeding and things like that. So every day the SOAP regime will help you to manage the patient properly. Okay, next case.
Can I just interrupt for 1 minute?
Yes, sir. Yeah.
When do you suspect there's an anastomotic leak? Usually, when does it happen?
Good question.
So 4 to 5th day.
4th to 5th day. Okay. And then what happens? There's no drain here. So what do you suspect? What happens to the patient?
Sir, abdominal distension
Vitals
with
will deteriorate.
vomiting.
Deteriorate. Fair. Last question. If there's a pelvic collection, what will you do?
Drains.
If
Pelvic,
possible,
through
ultrasound guided
abdominal or
drainage.
rectal, sir.
Fair. Next case. Yes, sir.
Next case. Any questions so far? Anybody? Hello? Any questions?
No, sir.
Okay,
No,
carry
sir.
on. Second question. Second case.
Second case, 56-year-old male, known case of necrotizing pancreatitis. His status post pigtail insertion came with complaints of chills and discharge over the pigtail insertion site. It's 2 days. There is leakage of foul-smelling purulent material from the pigtail insertion site. No history of fever, abdominal pain. He's a known case of diabetes mellitus on metformin, and he has had no significant surgical history. The history of the patient is patient presented with complaints of pain in abdomen and fever for 1 week in the month of August in another hospital. He was admitted in May 2024 for acute pancreatitis. He was managed conservatively then. Now, in the month of August on admission, like his per abdomen examination had epigastric tenderness and epigastric mass was noted. Further, in the first, there was a CECT done in the month of May, which was showing fatty infiltration of liver and diffuse hyperattenuation of the neck, body, and pancreas with peripancreatic fluid. And in the month of August, when he was admitted, these were the investigation findings, which were all within normal limits.
Okay.
Except
Now,
for mild.
Yeah. Wait, Vinod. What are the questions you would like to ask from einass about this patient? One important question.
Drain. When was the drain placed and why?
No, yeah, you can ask that question, but more importantly, no, why is not a question you should ask. You should know why it is being placed. Nobody places drains unnecessarily.
But
So, Yeah, when was the drain placed? Yes, that is a good question. But more importantly, what is the history? He has had an attack in May, he's had a further attack in August. So this is recurrent acute pancreatitis, possibly. So
Yes, sir.
what question will you ask? And will it have ramifications in your management?
Gallbladder stones
Huh?
calculus.
You know, you have to find out the etiology, no? Whether it
Yes,
is
sir.
gallstone related, or is it alcoholic, or is it, primary pancreatitis. Very rare for primary pancreatitis to have sudden acute, sudden episodes in the short span of time. They can run
Yes.
a chronic course, but generally they don't have these acute episodes. So acute episodes, usually the two main causes are the alcohol and gallstone.
Gall.
So you should know, you should ask einass what is the possible etiology in this patient. Einass, do you know?
Sir, he did not. Gallstones are not there. So, like ultrasound was done in the month of May. So,
Yeah.
gallstones are not there, and sir, the patient is not giving the history of consuming alcohol, sir.
But the
Yeah.
gamma glutamyl transferase is raised, isn't it? 204,
Yes, sir.
which is very suggestive of
Alcohol.
acute liver damage. Need not be alcohol.
Yeah.
Acute liver damage.
Okay.
Yeah. Okay, carry on, carry forward. Any questions? Anybody? All of you feel free to interrupt if you don't understand or you want some clarification. You can ask. All of you are at liberty to ask Vinod questions.
Does it make a sir asked a very pertinent question? Does it make a difference for the patient to know the etiology, or only for us? Pat ourselves
Even
on
for
the back.
Patients also, sir.
Even for us, sir.
What difference for the patient?
Lifestyle changes in the
Lifestyle modification.
Oh, lifestyle. Okay.
No, but actually, for example, if you have gallstone pancreatitis,
Yes.
you have to deal with it first, no? You have to
Yes, sir.
do an ERCP, and then,
Sure.
even before you do anything else, you have to do an ERCP and, put a stent and remove the gallstones, from the bile duct. So you have to clear the bile duct. So that is one. And second thing is, if it is alcoholic, you have to also concentrate on whether there is already significant alcoholic liver damage, which will have implications in your surgery. If you are planning surgery, anesthesia on a already damaged liver. Second thing is, if already there is liver damage, you may have want to assess if there is portal hypertension also. And portal hypertension along with this, surgery will be much more hazardous and dangerous. So all of any question that you ask has to have implications in terms of your management. So that is why it is important to know what is the etiology. Okay, Einass, continue.
Yes, sir. CCT abdomen pelvis was done on 20th August. It showed walled off necrotic pancreatic collection, which was extending to the lesser sac and the subdiaphragmatic region with a query pancreatico-pleural fistula. The volume was given as 1036 cc, and the duct with interrupted duct ends were seen communicating with the walled off necrosis, and complete SMB thrombosis with collaterals was seen. Further, CT-guided tail catheter insertion was done on 22nd of August, and the pigtail fluid analysis showed an elevated amylase level, and culture sensitivity showed of E. coli, which was sensitive to all the antibiotics. A check CT abdomen was done on after 4 days, which showed enhancing hypodense collection with air foci within, and it was seen to arise from the proximal body of pancreas, which was measuring about 6.5 to 7 and 7.7 centimeter, and the volume was around 170 cc, located posterior to the stomach, which is also extending into the left anterior and posterior pararenal space. A second pigtail insertion was done through a CT-guided procedure on 29th, and they monitored the pigtail output daily, with the first pigtail having an output of around 920 ml, and the second pigtail having an output of around 720 ml. The Yes.
Just a minute. Now, Vinod,
Sir.
do you think that this pigtail insertion business is going to work or not?
No, sir.
Why not?
There is a necrotic material.
Forget necrotic material. She said
And
something very
also,
important.
there is a pancreatic duct disruption and connection with the.
Yeah. Now you got it. See,
Yes.
when there is ductal disruption, unless that is amenable to be stented, which is usually not the case. In acute pancreatitis, stenting a disrupted duct is, almost very hazardous. But it is probably not possible also. So when there is ductal disruption, and as you said, it is a process going on for some considerable period of time, there is associated possible solid necrotic material. So the pigtail insertion is not going to work. But why have they done it, and is it useful? Do you think what was the thought process behind the gastroenterologist draining this?
It's a symptomatic relief, like
Relief.
Not symptomatic. He's not got much symptoms. He's not in much pain or anything.
Infections.
Correct. So first of all, you drain the fluid and prevent it from getting infected. But potentially, when you're putting a drain into something, you can also cause infection from outside. So that is also that you take that risk. But what you are trying to do is to drain the collection and hopefully settle the patient, and then think about surgery if at all. Maybe improve the patient nutritionally and everything, and then think about surgery. But I can't think of much in terms of advantages putting a drain, especially if you are considering the surgical intervention. Rajay Ballal sir.
Yeah, no, sir. One related question. There is an SMV thrombosis here.
Yeah.
Right? And then you have a similar patient, but there's a thrombus in the portal vein. Would you be worried? Similar, or everything else is same, pain abdomen, suspected pancreatitis, and then instead of the SMV, there is a thrombus in the portal vein.
Much more dangerous, isn't it?
Yes.
I
I think somewhere in the back of the mind you must think of malignancy, no, sir? Somehow there is SMV thrombosis is fairly common in pancreatitis. But if there's a thrombus in the portal vein, much more likely to be malignancy, I think, sir.
Yeah, certainly you should.
Underlying malignancy which is produced as pancreatitis, sir. No, sir?
Yeah, potentially, definitely you should think about that. And or, as sir said, one is that, or the severity of the pancreatitis is such that the entire splenic vein and the SMV is leading on to portal vein thrombosis.
Fair, sir.
Okay. So now, Vinod, you have a patient like this. How will you manage this patient? Has he lost weight, einass?
yes, sir. Not very significant, sir. Like he gave.
What is his albumin level now? What is his albumin level?
Sir, his albumin level is it was around 3, sir. 3. 3.
Okay.
3.
Okay. Now, how will you manage this patient, Vinod?
One is laparoscopic removal of that necrotic material, sir, or endoscopic or open, sir. 3 things are there.
The endoscopy, how will you do it? See, everybody, even Dr. Gurushantappa that day kept on about endoscopy. I think in the very acute situation when there is fluid collections,
sir, he walled off.
Endoscopic management is difficult because you don't have, you need a proper pseudocyst for you to then put in these approximating stents. So you need a thick walled pseudocyst where it will be fairly successful. You can also, after putting the stent, you can go in there and endoscopically remove the necrotic material, the necrotic pancreas and everything. All those things you can do. But in an acute fluid collection where there is generalized collection, endoscopic treatment is quite difficult, because where are you going to, if you can't create a channel between the general peritoneal cavity with the stomach.
Sir, here they said it as walled off necrotic pancreatic.
Yeah, but this is you have to see, this is walled off, but is there a have they mentioned it as pseudocyst? Have they mentioned the thickness of the pseudocyst? You need all those information.
Oh, sir. Okay.
Otherwise, you
So
can't.
I think they had mentioned that it is a query infected pseudocyst also. I don't know if
But what was the thickness of the pseudocyst?
next to CT. They've not mentioned the thickness, sir, but when we see
It
a
is
CT,
important. Yeah. So
but when we see the
important.
CT images,
Yeah.
That is the CT done here, sir. Like there was one CT done here, which was
show the CT.
Yes, sir. After admission in our hospital, there was a CT done here, sir.
Yeah.
And
Okay. Show the CT. Yeah.
yes, sir. And like these are the findings, sir. Like they had told that it is completely there's very less pancreatic normal tissue. The tail and body of the pancreas is showing a lot of necrotic material. And here they had the necrotic material is extending up to the spleen. And
So there is no walled off. It is not walled off. It is generalized.
yes, sir.
So
But
this
in the
this cannot
reporting
be
they had
managed. This cannot be managed endoscopically.
And it is also extending till body and tails.
Yeah. So see, impossible. See, there are a lot of caveats for endoscopic drainage. It should be in the lesser sac generally, though.
Yes, sir.
With the help of endoscopic ultrasound, even distal areas, areas part distal from the stomach can also be managed. Even sometimes they will even do the jejunum. But
Jejunum.
yeah, but the thing is, with endoscopic ultrasound, the what shall we say, the range of endoscopic drainage procedure is improved, but it should be a walled off, properly walled off collection with thick wall, so that you can drain it properly. See, because you don't want to, body has endeavored to wall it off properly, and by doing an endoscopic drainage, you don't want to convert it into a general peritoneal, peritonitis like picture. So you have to be careful. So in this particular situation, I don't think you can consider doing a endoscopic drainage. Certainly laparoscopic. Yeah.
You must read that last sentence, I think, sir. It is abutting the psoas muscle inferiorly, sir. So it's fairly extensive, like you said, sir.
Correct. It is extensive. Right, yeah.
Yes.
So it is probably not. See, the thing is, if it is confined, then yes. But now here it is very generalized, and you will never be able to drain all of that, and the patient will not get better till all the all the necrotic material is removed and the thorough wash is given. So there are limitations to endoscopic drainage. In this case, certainly don't say endoscopic drainage. You will not be right. Okay, so laparoscopy, yes. What are you going to do in laparoscopy?
I'll open it and suction, and I'll remove the necrotic material, sir.
Okay, then?
Where will you open, doctor?
Where will explain the procedure. How will you open it?
Yeah. Where is this collection basically? Where will you open it?
Will you be able to do a cystogastrostomy in this patient? Is what sir is asking. Also,
no, sir.
The procedure also, both. So you can't do a cystogastrostomy because it is not a proper cyst. It is very extensive. Okay.
Yes, sir.
So that is ruled out. So what will you do? How will you go about? Where will you go in now? Tanya?
Sir, greater curvature of the stomach, we will separate
diagnostic lab.
Who was answering?
Sir, please, Nikita. So we have to go posterior to the stomach, sir, to visualize the cyst, whatever we have seen in the CT.
No, so what will you do? How will you? No, don't give us
yes, sir, we have
statements. What will you do? You are there. You have gone there. What will you do first?
we have to separate the omentum from the greater curvature from the stomach,
You
sir.
have to go into the
Gastrocolic
gastrocolic
ligament.
Yes, sir.
Open the gastrocolic omentum, go into the lesser sac, because majority of the pseudocysts
Collection is
will
in the
be
lesser sac.
placed in the lesser sac.
Yes, sir.
So, and then lift up the stomach and visualize the pancreas, remove all the necrotic pancreatic material. Be very careful because there is already SMV thrombosis. So potentially there can be a lot of bleeding. You have to be very careful and remove all the necrotic material, give a thorough wash, and then place drains.
Drain.
You place drains. You can even adapt what is called as
Sump
sump
drain.
drains. What is sump drains?
Sir, it has the
Double-
mechanism of like flowing in and collection, sir. Like suction, continuous suction can be maintained. So in
Controlled
order to
pressure,
prevent
sir.
the
Just put a
collection.
drain. What? Just put a drain and put suction.
It
Controlled
allows
pressure.
to come out
Two-way.
also, like two-way.
No, what will happen is with the principle of sump suction is that there is a bigger tube outside which is fenestrated, and then there is a smaller tube inside, and the suction is applied to the smaller tube. So all the necrotic material and fluid will get collected in the bigger tube through the fenestrations, and then the smaller tube will suck it out. So that way there will be no blockage of the drain. Or sometimes if you apply too much suction onto the outer tube, then if any vessel or something gets this one, you can have torrential bleeding from there. So that cannot happen with the sump suction. So you have to put a sump suction probably on both sides of the both on the left and the right side. Place it strategically so that all the fluid collections are all drained, and what future collection may happen will be collected and drained through them. And you can irrigate also. That is the advantage of sump suction. You can, through the inner tube, you can also irrigate. So that way you can dilute the pancreatic, the enzymes and all that, and prevent further enzymatic destruction and digestion of the tissues. So that is what you have to do. And or what other option you have? Laparoscopic, you said. What else?
Open the laparoscopy.
Huh?
Open.
There is also another one.
Minimally invasive. Not laparoscopy.
Yes.
That's what sir wants, I think. No, sir?
Yeah, yes. What is
From
that?
the posterior.
Yeah, what's it called?
Ward.
Huh?
Wards.
Ward, sir.
What?
How do you spell it?
VARD.
Stands
What
for?
is that?
Video assisted retroperitoneal
Retroperitoneal.
Drainage. Yes. So basically you go into the retroperitoneum, and it will be a smaller incision. You can put a scope through that, and then you can remove all the necrotic material and then place a drain. So the advantage is, but that should be a limited, less invasive and hopefully less traumatic to the patient. But there are very specific indications for that. Sir, Pralad sir?
For this, it may be difficult, I think. No, sir, because
Yeah,
it's
for
expanding
this,
fairly inferiorly.
it is not possible for this.
Yes,
The next
yes.
other option is open.
Open, yes.
Yeah. So
Sir, what
in
about the
open,
duct, sir?
huh?
Ductal disruption, because that is continuously flowing out.
Yes.
So
I
at
thought
this
sir
moment,
said it initially, no? He said if you can stent
Yeah.
it, excellent. But maybe difficult, he said.
Yes, sir. Yes.
see, at this stage, I don't think you can do anything with the duct,
Duct.
because or you can, if you can see the duct point of ductal disruption, you can suture it off, because possibly the distal end of the pancreas will all be necrotic and dead. So you can suture it off, but you can also wait till such time that the patient recovers and then do an endoscope ERCP and then stent it later. So what are the problems that you are likely to encounter when you do open, let us open or laparoscopic surgery? Vinod. Hello, Vinod.
Hello, sir. Hello, sir.
What are the problems you are likely to encounter? I think we are already past 10 o'clock. Last question for you. Yeah. You have to read up. Nikita.
Sir?
Praveen, are you there?
Yes, sir.
Praveen, complications during surgery.
Sir, splenic injury, sir.
Splenic injury.
Yes.
Yes, okay. I told you already. Okay, Nitya.
Extensive bleeding.
Correct. Significant torrential bleeding can happen. This is all very inflamed tissue and there is already superior mesenteric vein thrombosis. So there will be a high pressure system. So potentially there can be significant bleeding. And then what else? As you are manipulating an infected necrotic material, what can happen? Patient can go into endotoxic
Shock, endotoxic
shock. So patient can go into shock.
Anesthesia.
So you have to warn the anesthetist. Patient should be filled up properly, because once you start manipulating the area which is infected, and you remember these are all usually polymicrobial because they've been going on for some time. So you have to be careful. You have to start, obviously give them, carbapenems is the right choice of antibiotics. In addition, if you want, you can use anaerobic cover as well. And then, the patient should be filled up properly before you start the procedure. And potentially they can go into endotoxic shock, bleeding. Those are the two things you have to watch. And then, of course, you have to look at their, clotting and PT-INR and all that, and have blood ready. And you may need to give vitamin K, FFP, and all these things. So you have to be ready for those. Those are the two important complications that can happen on the table. And of course, as Praveen said, splenic injury, especially when you are trying to deal with necrotic area around the tail of the pancreas, you can potentially cause injury to the spleen as well, because it's all very inflamed, and it is not a normal kind of anatomy there. So these are the things you should be worried about. What is the last question, Vinod? What is the long-term outlook, let us say, of this patient? Vinod?
Hello, sir. Patient, he'll become if chances of exogenous and endogenous hormonal deficiencies.
So they can become diabetic, and also there will be pancreatic insufficiency. So you may have to supplement lifelong.
Yes, sir.
So there will be significant weight loss, indigestion, or what malabsorption, all these things, steatorrhea, all these things are there. You have to deal with that. In addition, the patient is certainly going to become diabetic. So brittle diabetes. So you have to manage that also. Okay, I think you need to buck up and study. I think we have we just stuck to basic clinical signs and symptoms and management of the patient on the table and on the wards. It's not a theory class. Ward rounds is about assessing your knowledge as to how you pick up these things and how you manage them. Okay, so you have to, the mind should be much more alert, and it should be sharp, picking up clues. When the examiners give you clues, you have to pick it up and answer those questions, and answer to the point. Don't unnecessarily invite trouble. Okay. Good night, sir.
Good night, sir.
Sir, thank you so much.
Good night. Thank you very much, sir. Thank you.